Hello everybody, this is Dr. Kevin Connors going to talk to you about some standard blood markers that are involved with digestive issues and are sign of some digestive problems. Um, these can go, would be signs of other things as well, but this is, um, there's not a lot of standard blood tests from your CBC or your complete metabolic panel that are going to be suggestive of digestive issues, but there's a few. So we're going to go over some of these. So we're going to be going over total protein, albumin, globulin, the albumin-globulin ratio, or AG ratio. The BUN, sorry, that's a typo there, BUN, blood urea nitrogen, amylase, lipase, and eosinophils. So these are the ones that we're going to go over in this section. We will be covering all of the biomarkers in different videos. So look for them in different videos. So when we're looking at these, it seems like amylase is a little, or eosinophils being a white blood cell is a little out of place. But it does tie to digestion issues, so that's why it's in this section. So albumin and globulin are serum proteins. They're blood proteins on this list. So why are we screening for these? Because they can show us different nutritional deficiencies. They can help us assess different functional digestive processes and possible problems. And they're part of our check for dehydration. And I'm going to have a video on looking at dehydration. And we're going to have videos on different specific problems and the corollary to blood tests and what you would see in a blood test typically with that specific problem. So look for that. Albumin and globulin have been historically part of an ominous sign that can pinpoint more serious disease like cancer as well, because it has to do with liver function. So total proteins. So this is the range. You see two lines on that smaller white box. The optimal range is 6.9 to 7.4. That second line is the international units in an international test. So the first line is in a US test. 6.9 to 7.4 is optimal range. If you haven't yet seen my video on the difference between standard lab ranges versus functional optimal ranges, make sure you watch that. That's why we show you this box, your standard range. Maybe you went to your doctor and they did a test and you were at 6.2 for total protein. They said it's normal, you're good, you have a normal blood test. Well, we're looking at functional ranges, these optimal value ranges that are different than your standard range. So we're trying to catch disease process, or let's say dysfunction process, before it becomes an emergency room visit. That's the whole idea. Now in our ODX software, you'll see the large box. If you get your blood work done through us, you'll see this large, I just took a clip out of proteins here, and it shows total proteins, albumin, globulins, and albumin-globulin ratio. This is what our software through ODX software looks like. So it gives you a nice, colorful picture. In this example, this person has a total protein of 8.2. That would be above the standard reference range. Remember, different standard lab ranges can vary, but it's certainly way above our optimal range. So it's in the above optimal range. The other the albumin is in optimal range in this example. Globulin, total globulins is above the optimal range, and AG ratio is below optimal. So this is what our software looks like. If you get a whole giant picture of all your lab ranges in our software, but I just took a clip out of proteins. What's the significance of total protein? So high levels of total protein that is above 7.4 is more likely to be increased in the globulin fraction than the albumin fraction. Can be different, but that's the most likely, unless there's dehydration that's causing this. And remember, we're going to have a whole section on dehydration, but total protein elevation can be a sign of dehydration, can be a sign of liver or gallbladder dysfunction as well. Low ranges in total protein can be hypochlorhydria, and you're going to see a lot of these labs do point to hypochlorhydria. Remember, hypochlorhydria is a decrease in hydrochloric acid production. And if you watched the previous video, you noted that I said something like, I believe that it is probably the #1 issue worldwide, certainly in America, and it can lead to a lot of dysfunction, digestive dysfunction in our body when we can't break down or digest nutrients in the stomach, and it can lead to H. pylori growth, and I have a whole blog post on that too, so make sure you check that out. Hypochlorhydria is the first thing really that a person should check out when they're having any health issues. You should address hypochlorhydria because that's most likely a piece of it. I'm not saying it's a cause of everything, but it's certainly a piece that you need to check out. Low total protein can be tied to digestive dysfunction and or inflammation if you're not absorbing, malabsorption issues. Inflammation can decrease total protein, liver dysfunction, protein deficiency. This person's not eating protein. Maybe they're on a vegan diet. They're not getting adequate protein. Poor protein breakdown. Of course, when you're not breaking down your proteins into amino acids, you're not going to be absorbing them and making new proteins that you need in your body that would be shown in this test. And obviously malnutrition, person's not eating, and they just need protein consumption, amino acid need. Now the difference in these proteins, we're looking at albumin levels. Again, in this white box, your standard reference range, American units, international units, second line. Optimal range is tighter, so our optimal functional ranges are tighter. Albumin is primarily made in the liver, therefore levels are affected by liver function. So liver dysfunction is going to affect albumin levels. Helps with water distribution. Albumin acts as a hormone transport protein. Transports testosterone primarily. High levels of albumin on your blood test can point to dehydration or overhydration, and I mean excess hydration. So excess hydration leads to dehydration. That's why I put that in there. Low levels of albumin are tied to hypochlorhydria, low HCl production, because you're not breaking down the protein in your gut in order to absorb amino acids to make albumin. Your liver dysfunction, oxidative stress, like toxic exposure and things, vitamin C deficiency, and it can lead to edema and tied to edema. Common with people with serious disease like cancer as well. Total globulins. So total globulins is what you're going to see on a CBC, a complete metabolic panel. And it is composed of different fractions of the globulin molecules. If they're elevated, you can ask to run a protein electrophoresis test. That's not as commonly done. It's certainly not a normal test done, but that will give you a breakdown of the fraction that is really causing issues because it's tied to different problems. It's made in the liver and in the cells. Helps with transport of proteins in blood. It's elevated with hypochlorhydria. Again, liver damage, liver dysfunction, cirrhosis can elevate globulin levels. Immune activation will elevate globulins. Oxidative stress, toxicity, poisons, you're exposed to different toxins, heavy metals, chemicals, foodborne toxins can elevate globulins. If you have a sensitivity, real common, when you see a spike in globulin, it can be a sensitivity to a drug. So a medication that a person is taking or even a supplement they can have a sensitivity to, it can really cause a spike in globulin levels. You got to look at that as well. Low globulin levels, digestive issues, inflammation, same thing as albumin, immune insufficiency, especially if your gamma globulins are low, if you do the electrophoresis test. The BUN is the blood urea nitrogen. It is actually the ratio between the production and the clearance of urea. It's made in the liver. Urea is the final product of protein breakdown. It is a screen for renal insufficiency and for liver dysfunction. It's a screen for digestive issues and dehydration. It's elevated if there's an increased production of it in the liver or a decreased excretion of urea in the kidneys. So therefore it's a sign of renal disease. It's tied to hypochlorhydria. It is a sign of excess protein, dietary protein intake. That can elevate it. Adrenal stress, because cortisol will increase BUN. Dysbiosis in the gut can affect BUN. Edema will affect BUN. If the person has ascites, their blood urea nitrogen can be elevated. Anterior pituitary dysfunction can cause this because of the hormones that are made there. It's decreased if the person has low dietary protein intake. They have malabsorption issues, pancreatin insufficiency, liver dysfunction, posterior pituitary dysfunction. Another sign of digestive issues as well. And then the AG ratio. This ratio is elevated if there's an increase in blood viscosity, poor vascular tone. If the person is sedentary, they have, let's say, chronic disease, and they're just not getting up and moving around, you could have an elevation in the AG ratio. If the person is elderly and they're, in a bed in a nursing home, it can be a sign of dehydration as well. It is depressed if there's liver dysfunction. It can be depressed in immune activation. It can be depressed in with decreased blood viscosity. If the person's taking daily aspirin, maybe taking too much of that, taking unnecessary blood thinners, that's a sign of excess use of blood thinners. Eosinophils, again, seemingly a little bit out of place because they're a white blood cell. Why are we talking about white blood cells? We're talking about digestive markers because they are tied to intestinal parasites. They're tied to food allergies, food sensitivities. When you have antibodies to different foods and you're having a high reaction, they can be tied to environmental allergies, toxins in the environment that are causing an eosinophilic elevation. Eosinophils also digest antibody-antigen complexes, therefore they're tied to later stages of inflammation, so they can show late-stage inflammation as well. They're high again in intestinal parasites, things that I just spoke about, food sensitivities, allergies, environmental things, and it's common to be elevated in asthma patients. Amylase is an enzyme. Anything you see ASE at the end means it's an enzyme. Well, amylase is the enzyme that breaks down carbohydrates. We spoke about this a little bit in our last video. It's made in the salivary glands and in the pancreas. It digests skip that part. It doesn't digest antibody complexes. It's really a carbohydrate. Breaks down large carbohydrates into sugars. That's the whole purpose of amylase. It can be elevated with pancreatitis, especially with acute pancreatitis. And it can be elevated with issues with the salivary gland, tumors and things. Low in pancreatic insufficiency and issues with the salivary gland. So contrast that to lipase. Lipase is an enzyme that breaks down fats. We talk about elevation. I said that amylase can be elevated in pancreatitis, typically acute pancreatitis. Lipase is elevated in acute and chronic. It tends to hang out longer than amylase. So look at that, especially if the person's going to have very acute abdominal pain. Pancreatitis can be very serious and needs to be treated right away if it's an infection. can be with issues of the gallbladder, and it's low with pancreatic insufficiency. Lipase is an enzyme that breaks down fats. It's made in the pancreas and in the liver. Remember, amylase was made in the pancreas and the salivary glands, and when you start to chew your food, amylase starts to break down carbohydrates. Well, lipase is not expressed until we get down to the duodenum. So when food goes into the mouth and down the esophagus, into the stomach, you're really breaking down proteins, you're breaking down carbohydrates. You don't really start breaking down fats until it gets into the small intestine, where it's met with lipase enzymes from the pancreas, through the pancreatic duct, and from the gallbladder secretes lipase that was bound to bile that was actually made in the liver. So the liver makes lipase as well, transports it through the bile, through the common bile duct with the pancreatic lipase to the duodenum, the first part of the small intestine, to digest fats. And when there's fats, remember physiology, when there's increased fat in the duodenum, the gallbladder will contract and squirt more bile in there, giving it excess amount of lipase to break down that fat. When you have absence of a gallbladder, you just have a trickle of lipase that's produced in the liver, that's entering the duodenum, and it can, if you eat a fatty meal with the absence of a gallbladder, could be some insufficient breakdown of fats. That's why taking digestive enzymes, particularly lipase, and some bile salts, can be helpful if you do not have a gallbladder to help break down fatty meals. It's elevated with pancreatitis, I said, and pancreatic insufficiency is your main common lipase deficiency. Typically, you won't see a lipase deficiency with gallbladder removal because you're still making it in the liver and you're still transporting it into the small intestine. You're just not getting the concentration of it after you eat a fatty meal. You're just getting this trickle of transport from the liver. You still have a common bile duct, you just don't have a gallbladder. So you won't see depressed levels of lipase because you have a gallbladder removal surgery. So that's not an issue. Okay, so that gives you just a brief overview of some of the tests that you'll see in the CBC, the eosinophils, and the complete metabolic panel that tie to digestion. We'll be getting into more specific conditions in our next video, so continue learning. Bye-bye.